Good afternoon or good morning. The title of my talk today is Right Patient, Right Technique, Optimizing HA or Hyaluronic Acid Therapy. Briefly, my name is Tom Best. I'm a professor of orthopedics, family medicine, biomedical engineering, and kinesiology at the University of Miami here in Coral Gables, Florida. I also serve as the Vice Chair for Research in the Department of Orthopedics, and I'm the Fellowship Director of the Primary Care Sports Medicine Fellowship. I also serve as a team physician for the University of Miami Department of Intercollegiate Athletics, and I'm the medical director for the Miami Marlins. These are my disclosures regarding today's talk. So to begin, we have three learning objectives for today's talk. First is to examine best practice approaches for clinical decision-making in considering HA injections for knee OA or osteoarthritis treatment. Secondly, to identify specific patient populations, including differentiating among grades of OA severity that may benefit the greatest from HA injections. And finally, we'll examine a step-by-step approach, or my approach, to intra-articular injections of the knee. To perhaps set the framework for this afternoon's discussion, I'd like to start with a review of a database from United Healthcare Insurance System. This is a very large database, and looking at this briefly here over a 5-year period, this included a total of 11 million patients undergoing over 200 million patient visits. And as you can see here, roughly 13,000 patients underwent total knee arthroplasty in a 5-year period, that being from 2004 to 2009. Now, what's interesting and relevant to today's discussion is if we take a look at the non-operative treatment during this same time period. And as you can see here, 10% of patients received physical therapy, approximately 3% an unloader brace, typically a medial unloader brace, roughly 0.5% received acupuncture, roughly 60% of patients received either intra-articular corticosteroid injections or viscosupplementation hyaluronic acid injections. And finally, as you can see, roughly 20% underwent arthroscopy and debridement lavage. Now, interestingly, when you look closer at the patients who received these injections, again, 60% of these patients received injections, and approximately 75% of those patients actually received injections within a year prior to their total knee arthroplasty. So really then, what's the take-home message of this slide? Well, as we can see, there's significant gaps exist in practice patterns. And we'll speak more to this during the talk today, which really highlights, I think, the importance of trying to develop some consensus and really understanding the guidelines that are available in terms of helping us to manage patients with osteoarthritis of the knee. But before we get to the meat of the discussion today, let's take a closer look at osteoarthritis and perhaps some data that are relevant to today's discussion and somewhat alarming. This is a slide, it's an aggregate of several publications, as you can see. And what we're trying to illustrate here is the fact that osteoarthritis of the knee, typically the way many of us were taught, for example, when I was in medical school over 30 years ago, we thought this was a disease of quote unquote old age people. It was wear and tear on the articular cartilage, mechanical breakdown. And as we'll see in the discussion this afternoon, it's far more than that. What this has translated into, most importantly, when you look at this slide, is the fact that when we look at the diagnosis of osteoarthritis of the knee, it continues to be made in patients much younger. For example, I was in clinic yesterday and probably saw 5 patients under age 35, one with a history of an ACL reconstruction, the other 4 no definable of event that they would identify with developing knee pathology or knee injury. And they were diagnosed by X-ray as well as clinical examination and presentation with osteoarthritis of the knee. So then we look further and we say, okay, for those who undergo total knee arthroplasty, what is their outcome? Because that's a really important question, and that is changing day by day. But here's a study that was published in the journal Core, Clinical Orthopedic Related Research, in 2014. Now, this was a national multi-center study, and of significance, these were senior investigators, probably doing on the order of 400 to 500 total joints a year. So high volume practice, and these were very high profile surgeons, including colleagues of mine at Ohio State, Drs. Lombardi and Barron, as well as Dr. Cloissy from Washington University in St. Louis. And what we see here is, looking closer at this slide, approximately 2/3 of the patients who undergo arthroplasty actually feel quite good afterwards. Interestingly, however, as you can see highlighted here, is that approximately 1/3 of these patients, however, have residual symptoms. And these residual symptoms can vary. Most commonly is knee stiffness. Now, in a follow-up study, what we saw in the same journal in the same year is, interestingly, despite the fact that 1/3 of these patients were demonstrating residual symptoms, 89% of them were able to get back to their activity level at work in particular, and this included heavy mechanical lifting and so on. However, when you take a look at the combined literature for total knee arthroplasty, as you can see here, and these are 14 studies that we've selected from the literature, and as you can see here, up to 20% of patients who undergo total knee arthroplasty are somewhat dissatisfied following their surgery. Furthermore, as I mentioned earlier, the landscape of osteoarthritis is changing. This is a study that was published in the Journal of Bone and Joint Surgery in 2012. And what it shows, it breaks down 4 different age groups. As you can see here on the left-hand side are young people, ages 18 to 44. We move to the middle of the slide, which is ages 45 through 64, 65 and plus, and then aggregate data. And as you can see here from this slide, importantly, is the fact that what we can't explain by simply looking at obesity and population growth is this dramatic increase in the incidence of osteoarthritis of the knee. Most significantly, as I mentioned earlier, in a much younger population. And as you can see here, at least in this particular study, it was in the ages 45 to 64. So then we say to ourselves, well, again, let's go back. I presented some data earlier looking at total knee arthroplasty and volumes. Here's a study that was a rather landmark study published in JAMA back in 2012. And as you can see here, we're looking at 2 different metrics. First, and again, these are from Medicare data. And as you can see here, over 20 years, you can see the growth in total knee arthroplasty here in the United States, as well as revision arthroplasty. When we look further, of course, what you can see is that there's been an approximately 160% increase in the total volume of arthroplasty surgeries done, and roughly 100% increase in the number of revision surgeries that are done as well. Well, this study was then taken one step further, and again, this was published in the Journal of Bone and Joint Surgery in 2018. And what this study did is looked at, again, some aggregate data and then did some computer modeling using 2 different approaches. One is what's called a linear regression approach, and the second one is what's called a Poisson's regression model projection. And as you can see here, total hip arthroplasty is in blue, total knee arthroplasty is in pink. And what we can see here, again, these are aggregate data projecting out to the year 2030, and you can see the rapid increase that continues to be projected, both looking at hip and knee arthroplasty. Okay, so the take-home message so far from this discussion is that these are common surgeries. Secondly, that there's an increase, not an exponential increase, but certainly a rapid increase in the volume of these arthroplasties being done. There is a subset of the population that undergoes total knee arthroplasty and revision that is not necessarily satisfied with their results. And finally, and perhaps more importantly, is the point that we're diagnosing osteoarthritis of the knee and hip, I may add, in a much younger patient population than we ever did before. So the next part of this discussion then is to start to understand more about osteoarthritis in terms of its pathophysiology. As I'm sure everybody on today's discussion understands, it starts with understanding articular cartilage, the biology of articular cartilage, and what's referred to as the mechanical loading effects on articular cartilage. And as we all know, articular cartilage, interestingly, is an avascular structure, so it has poor to little no blood supply. It's an aneural structure, In other words, it does not have a nerve supply. It's an alymphatic tissue as well. As a result of those factors, we know that articular cartilage has poor reparative potential. The way to think about articular cartilage is it's this dense proteoglycan and collagen matrix with embedded chondrocytes. And chondrocytes, of course, are the building block of articular cartilage. If we have any hope of any kind of regenerative medicine approach, it must involve the chondrocyte. When we look closer at the histology of articular cartilage, it has 3 zones. It's really a small structure when you look at it. It's about 2 to 5 millimeters thick. Interestingly, the chondrocytes only make up about 10% of the total volume of things. And finally, we know that articular cartilage is basically a very vascular structure with a lot of blood supply in there. So again, it's important to appreciate that chondrocytes really only occupy about 10% of the cartilage volume. So in essence, articular cartilage is really water. And in fact, it's 80% water by weight. Finally, we know that the type 2 collagen is the most important collagen within the articular cartilage. This slide looks rather busy, but it's got some important points that I think deserve discussion this morning. And the first one is, if you look to the right-hand side, we know that the glycosamines and chondroitin sulfate attach to the aggregan, which in turn binds to hyaluronic acid via its N-terminal protein. What that means, of course, is we have a biological mechanism, if you will, for supposedly using hyaluronic acid injections and having a direct conduit, if you will, to the glycosamine and chondroitin aggregans. Secondly, we know that hyaluronic acid is a large polysaccharide composed of repeats of glucosamine and glucuronic acid. And finally, the negative charge associated with the proteoglycans is trapped within this collagen matrix and water. So what that allows us to do, of course, is to say that if we can get this hyaluronic acid to the appropriate site within the knee, it has a good chance of binding to these basic building blocks of articular cartilage. Now, I mentioned earlier that certainly when I trained some 30 years ago, the teaching was that osteoarthritis is essentially a wear and tear disease. What that means, of course, is you get articular cartilage breakdown. This leads to further changes. At that point, we didn't understand, of course, that the subchondral bone was involved, but we now know that this is a total joint problem. More importantly, and the purpose of this slide is to also suggest that a large number of cytokines, as well as macrophages themselves, play an important role in articular cartilage homeostasis. And I'll have more to say about macrophages later, because we believe now that the macrophages are key building blocks, if you will. And there's what's referred to as M1 and M2 macrophages. And they're switching back and forth controls inflammation within the joint as well. And I'll have more to say about that later. So for those who are interested, this is a very nice article that was just published in the Frontiers of Veterinary Medicine. As many of you may know, a lot of what we understand from articular cartilage and osteoarthritis actually comes from the veterinary medicine literature, where a lot of the basic science that we've learned today has really been done in animal research. So this is a very timely publication. It just came out a couple months ago. And what this points to, as I mentioned earlier, is the importance of macrophages. And specifically, we now know that the immune system is involved in osteoarthritis as well. The term that's becoming more prevalent today is known as macrophage polarization. And what that means is we have 2 different types of macrophages. We have M1 macrophages. They generate a pro-inflammatory environment, and M2 macrophages that generate an anti-inflammatory environment. Some basic science work going on in our laboratory right now is actually suggesting to us, at least, that the infrapatellar fat pad may actually have a role in terms of signaling these macrophages to become M1 and M2, and then accordingly generate a low-grade inflammatory state within the osteoarthritis joint. So again, we know that the hallmark of osteoarthritis is articular cartilage degeneration, but more importantly, recently we're understanding that there's a at least a subset of patients, if not all patients, that have a low-grade inflammatory process within the osteoarthritic joint. So let's talk further for a couple of minutes about inflammation and biomarkers in osteoarthritis. Again, this is a very timely publication in the same journal titled Frontiers in Medicine. And at this point, at least, we know that OA now affects over 500 million people globally. Risk factors for osteoarthritis include age, obesity, sex, previous joint injury, meniscal injury, joint instability, malalignment, genetics, subchondral bone shape, muscle weakness and sarcopenia, and finally, metabolic disease. As I mentioned earlier, low-grade inflammation is increasingly recognized as an important factor beyond the simple way we learned of articular cartilage wear and tear. Importantly, and again, this is some work coming out of our laboratory right now, shows that there really is crosstalk and interaction between the synovium, the subchondral bone, the infrapatellar fat pad, and articular cartilage. I mentioned earlier the macrophages, specifically these M1 macrophages that appear to generate a pro-inflammatory cytokine production and low-grade inflammation within the joint. And then importantly, we're learning more and more that the future of osteoarthritis treatment is going to be accelerated by our understanding of identifying biomarkers, which can be used to identify phenotypes. And we'll talk more about this later in today's discussion. But suffice it to say, asthma is a very great example of a chronic disease where we now have identified biomarkers that allow us to predict those who are going to go on to more of an aggressive form of asthma. So in summary, we do have an unmet need in the osteoarthritis world to identify these biomarkers of disease and disease progression. Diagnosis of osteoarthritis. Well, on the left-hand side here is an intraoperative finding of a healthy knee. In contrast, on the right side, you can see the so-called osteoarthritic knee. We've got some changes in the subchondral bone. You've got articular cartilage degeneration, probably some degenerative meniscus tearing as well. Now, what's interesting, as I mentioned earlier, we recognize that osteoarthritis is probably a disease that initially we thought was, again, for people who were in their 50s and 60s, for example. What we're seeing more and more, people in their 20s and 30s, sometimes even late teens after, for example, an ACL tear. The interesting thing, though, is that many people are now suggesting that the history, specifically key questions, can probably make the diagnosis of osteoarthritis. In addition, however, it's critical that we understand the use of X-rays, and specifically the importance of the weight-bearing film. Now, this slide is meant to illustrate a very important point, and that is the importance of obtaining weight-bearing films. We see this all the time, that patients will come in from outside sources, they'll have X-rays, and the first question I always ask my residents and fellows is, was that a weight-bearing film? And why is that important? Well, as we can see here, if you look on the left-hand side, you see a view that looks relatively normal. The medial and lateral tibial femoral components look pretty normal. However, if we get a weight-bearing film, as we show on the right-hand side, you can now see, of course, the degree of osteoarthritis that wasn't appreciated in a non-weight-bearing position. Now, people have different ways of getting these examinations, but typically when weight-bearing films are obtained, they're obtained in 45 degrees of knee flexion. So let's briefly review a standard set of X-rays. This is the so-called lateral film. We can see the position of the patella. We can see the entire extensor mechanism, the quadriceps muscle, the patellar tendon. You can see the anterior part of the knee, the posterior part of the knee with the popliteal fossa. And this really gives us a nice look at the patellofemoral joint. More specifically to the patellofemoral joint, however, is the sunrise or merchant view, typically shot at about 45 degrees of flexion with the patient lying supine. And as you can see that retropatellar surface as well as any indication for lateral tilt of the patella. Here's your standard AP or standing weight-bearing film. And again, you can see on the left side, which is advertised as a weight-bearing film. However, when you get a true weight-bearing film, you can see the medial tibial femoral joint is pretty much obliterated. So again, the take-home message here is to make sure when you're assessing these patients and that you're getting a proper weight-bearing film. In that way, you can identify the tibiofemoral joint and any associated pathologies. Does this look familiar? Well, this is a great example, again, of somebody who came into clinic. If you look at the first slide on the left, this was advertised as a standing weight-bearing film. However, when we got a true weight-bearing film, you can see how the medial tibiofemoral joint surface is pretty much bone-to-bone contact. There's been a lot of studies looking at what's the optimal degree of knee flexion in order to assess for osteoarthritis. Here's a great example of a paper published almost 20 years ago now that's withstood the test of time and shows that when you're getting these films, probably in about 45 degrees of knee flexion for that AP and lateral film is really the way to go in terms of assessing a proper weight-bearing film. So we've talked a little bit about the epidemiology of osteoarthritis of the knee. We've talked about the importance of proper x-rays in terms of making the diagnosis. And one other point I think is important here to recognize is the fact that despite the fact we get x-rays, we do recognize that x-rays don't necessarily correlate well with symptoms. So for example, we can have a patient that has KL grade 1 osteoarthritis of the knee, so very minor changes. That particular individual, he or she can have minimal symptoms or can have very severe symptoms. The converse of that is somebody who's got advanced osteoarthritis of the knee, such as myself. I have grade 4 changes, and yet I have minimal symptoms. So what that leads us to is the important concept of not just treating the x-ray, which is what we should never do, of course, but treat the patient and his or her symptoms. So that said, let's talk a little bit about the challenges of treatment. Well, we know at the end of the day, at least in the year 2021, we're still understanding more and more about the biological mechanisms associated with osteoarthritis of the knee. We understand this important concept about phenotypes, and we'll spend a couple minutes towards the end of this morning's talk talking about that as well. And finally, we know that the only cure for osteoarthritis of the knee is total joint arthroplasty. So what does that leave us with? Well, this is a slide that's perhaps a little bit outdated, but it sets the stage for looking at our various forms of non-surgical treatment of this problem. And typically, we begin with medications such as acetaminophen or ibuprofen. We know, of course, though, that particularly with the non-steroidals, you can have problems with the gastrointestinal system, such as reflux and ulcers. We certainly see renal disease and uncontrolled hypertension in those who use anti-inflammatories improperly. So then we move on to agents such as intra-articular corticosteroids, and I'll have more to say about that in a few minutes. And then finally, arthroplasty itself. And so again, when I trained 30 years ago, this was really all we had for our patients with osteoarthritis. In fact, we probably learned the hard way that intra-articular corticosteroids, too many injections can be problematic. And that's another issue we'll talk about as well. So we fast forward to today, to the year 2021, and more of what some people refer to as a pyramid, and the fact that we've been blessed at least to have several studies, countless studies, supporting other approaches to non-operatively managing patients with osteoarthritis of the knee. And so this is an example. It's really sort of a summary of the literature and what's been suggested today. So if we look down at the bottom of the pyramid and we look at patients with mild osteoarthritis, exercise and physical activity is probably the mainstay of therapy. That includes physical therapy to correct any biomechanical problems such as range of motion, kinetic chain strength. Certainly in patients who are obese, as we mentioned earlier, that's a risk factor, so weight loss has to be at the top of the list. Orthotics at times can help. For example, if you have somebody with medial compartment change only, putting a orthotic into the shoe with a lateral wedge has been shown to help in some cases. And of course, there's a very rapidly expanding literature looking at the nutraceuticals, which is beyond today's talk, but certainly something of importance. From there, we move on to typically prescription medications, typically, again, looking at non-steroidal anti-inflammatories. We've talked a little bit about the problems that can be associated with that approach. And then we move on to things such as the COX-2 agents. We get into high-dose non-steroidal anti-inflammatories, which usually concomitantly will give them something like omeprazole to protect their gastrointestinal system, intra-articular corticosteroids, and then surgery. So we see this pyramid. There is some evidence for some of these agents. And again, we'll spend some time looking at a slide that illustrates some of the major organizations that have provided some recommendations, and really the fact that there's a lot of inconsistencies here. So then the question becomes, if we look at the left-hand side of that pyramid, where does HA fit in? And we're going to spend a couple minutes really trying to dissect out and understand the role of HA and when it should be used to optimize patient care. So as I mentioned earlier, this is really a summary looking at the different treatment approaches and what are the limitations. So if we start at the bottom of the pyramid, for example, with things such as patient education, physical therapy, occupational therapy, weight reduction, exercise, assisted devices such as braces and orthotics, the translation of that, the limitation of that, at least in clinical practice, is often poor patient compliance. We know, for example, that exercise is probably the best medicine, and yet 2/3 of our country still remains physically inactive. So we have a ways to go and hopefully some opportunities, and we need to develop the right strategies to increase adherence. I mentioned earlier acetaminophen. For a while, that became the drug of choice because of the side effects associated with non-steroidals. But as we know, high doses of acetaminophen can result in hepato or liver toxicity as well. I touched on this earlier, which is the non-steroidals, including the COX-2 agents. And again, we know the associated problems with the gastrointestinal system, as well as the cardiovascular risks, and finally, the renal complications. And then finally, as we talked about earlier, is total joint arthroplasty and some of the associated limitations, particularly the fact that in some studies, at least, up to 1/3 of these patients aren't satisfied after their treatment. So let's spend some time now talking about HA, or hyaluronic acid. Well, first of all, hyaluronin is a polysaccharide. It's found in all tissues and body fluids of vertebrates, as well as in some bacteria. It's abundant in loose connective tissue. It's synthesized in the cellular plasma membrane. Hyaluronin binds with proteoglycans to stabilize the structure of the extracellular matrix, as we saw earlier. So we have a way then to really think about this almost like glue. And finally, because of its physical chemical properties, various physiologic functions have been assigned to hyaluronic acid. So more specific to today's talk, then, not only is it found within all tissues, but specifically it's found intrinsically within the knee joint. We know that it provides viscoelastic properties to the synovial fluid. Viscoelasticity is an important mechanical property of all biologic tissues. And the way I like to explain viscoelasticity to my residents and fellows is, if you think of silly putty. Silly putty, if I pull on it slow, it will just stretch out over time. If I try to pull it quick, it kind of snaps in half. So what viscoelasticity refers to then is the mechanical properties of the tissue, and the fact that how fast you try to pull or stretch these tissues is how they're going to respond. The importance for today's talk, however, is that HA injections, hyaluronic acid in particular, does provide some viscoelastic properties to the synovial fluid. And we know that knee osteoarthritis is associated with the reduced hyaluronic acid synthesis and increased hyaluronic acid degradation. So we have a biological basis then to think about restoring normal homeostasis to the osteoarthritic knee and the use of HA injections. What are the changes that occur within the articular cartilage as the disease of osteoarthritis progresses? This is a great paper that was published in Bone Research back in 2016. And the take-home message from this slide, first of all, is that osteoarthritis is really more than just a problem with the articular cartilage, as I mentioned earlier. It actually involves the entire joint. That includes the synovial membrane, the articular cartilage, as we've focused on, as well as the subchondral bone. And as I mentioned earlier, we also think that the infrapatellar fat pad may be involved in osteoarthritis pathology. So now we want to take a look at some of the mechanisms for action of hyaluronic acid in the treatment of osteoarthritis of the knee. There are 6 major points to consider here. chondroprotection, so that's actually protecting the chondrocytes from breaking down. Proteoglycan and glycosaminoglycan synthesis, which we saw earlier is important in terms of articular cartilage foundation. Anti-inflammatory effects, mechanical modifications, subchondral bone alterations. As I mentioned earlier, osteoarthritis may in fact be a disease that's much more involving of the subchondral bone than we certainly thought about even 5 years ago. And then finally, there's some suggestion that HA can provide some analgesic effects as well. If we dive down a little deeper into the mechanisms of action and start with chondroprotection, this is a lot of biology that we don't necessarily need to get into today, but what I want to focus on is the fact that, again, there's a biologic mechanism here. The CD44 receptor is actually an important receptor on the articular cartilage membrane itself where the hyaluronic acid can bind. And importantly, of course, are the MMPs or metalloproteases. We know, for example, that these products, when they're expressed in high levels, can lead to articular cartilage breakdown. When we speak about proteoglycan, glycosaminoglycan synthesis, we know that as OA progresses, that these concentrations decline. And we know, of course, that HA injections do stimulate proteoglycan synthesis and they can delay progression of osteoarthritis. I mentioned earlier inflammation, and we know that HA has a very strong anti-inflammatory effect, probably mediated by IL-1 beta. Next, we know that there are some direct effects, mechanical modifications to the joint. That the viscous nature of the hyaluronic acid can lubricate the joint capsule. The degeneration is prevented through decreased friction. There's a reduction in joint friction that can provide therapeutic effects as the cartilage is protected from mechanical degradation. I mentioned earlier the subchondral bone. We know that that's a really important component of the progression of patients with osteoarthritis of the knee. And again, hyaluronic acid appears to limit some of these subchondral bone changes, particularly during the early stages of osteoarthritis. And finally, there's some suggestion now, at least in animal models, that single injections of hyaluronic acid can lead to a decrease in pain-associated behavior, and perhaps even specifically substance P. So just to kind of highlight some studies that you may be interested in looking at further, we now see within particularly the basic science literature, some very strong support for the use of hyaluronic acid and its ability to attenuate, ameliorate cartilage breakdown. We also know, as I mentioned earlier, that as OA progresses, there's the intrinsic proteoglycan and glycosaminoglycan production declines. Hyaluronic acid may be able to, through this expression of this one receptor here, ADAMTS4, hyaluronic acid may be able to limit that breakdown. Specifically, as I mentioned, hyaluronic acid treatments can stimulate proteoglycan synthesis and also delay the progression of osteoarthritis. Most of this, of course, is coming from the basic science animal model literature. I mentioned earlier the importance of hyaluronic acid in potentially reducing inflammation. Again, we learned decades ago that osteoarthritis is a wear and tear disease, but it's becoming much more appreciated that there's a low-grade inflammatory state within many of these joints. So our ability to limit that inflammation may actually suggest some novel treatment approaches that we'll talk about later. I mentioned earlier the importance of chondroprotection, right? Remember that the chondrocytes are the building block of articular cartilage. And what we want to do is try to reduce chondrocyte apoptosis or chondrocyte death while increasing chondrocyte proliferation. And again, as you can see, particularly in this one paper here, which is a rat osteoarthritis knee model, there's some suggestion that hyaluronic acid can in fact be chondroprotective. I mentioned earlier the mechanical effects. These are a couple of nice papers showing that you can alter the mechanical properties of the joint. I referred earlier to viscoelasticity of the joint, and that's an important concept as well. The subchondral bone, we've talked a lot about that already this morning, its importance in terms of the pathophysiology of osteoarthritis. And again, there's some basic science work suggesting that hyaluronic acid can limit some of these subchondral bone changes that are characteristic of earlier osteoarthritis. And finally, as I mentioned earlier, there's even some exciting literature suggesting that HA injections may actually decrease pain within an osteoarthritic joint. So again, how does hyaluronic acid work? Well, first of all, you have these entangled strands that are bonded with covalent bonds as opposed to peptide bonds. And this has an important role in terms of synovitis. And we'll talk more about that when we talk about the potential for phenotyping patients with osteoarthritis. And we certainly see this in clinic. One of my take-home messages is going to be that when we look at the potential for who are the right patients for hyaluronic acid, it's been my personal experience, and we have a data registry here at the University of Miami where we're cataloging all of those receiving HA injections. And it appears that patients who come in with this inflammatory state, and particularly some synovitis, they appear to be the patients that may in fact benefit the most from HA injections. I want to talk briefly about intra-articular corticosteroid injections. Now, again, way back when, we really only had short-acting intra-articular corticosteroids. So we could use Kenalog, dexamethasone injections, and even to this day, we know that these are very limited in terms of how long, what's their efficacy of action, if you will. Some studies have suggested up to 12 weeks. I think that's overly ambitious. My personal experience has been, and I've seen a couple of studies supporting this, that intra-articular corticosteroid injections probably provide pain relief for up to 2 weeks. Here's a really nice paper that we don't have time to talk about today, but I would direct to your attention, titled The Conservative Treatment of Osteoarthritis of the Knee. And it's a really nice paper, I think, that people should take a look at. So let's look a little bit closer at some of the guidelines I mentioned earlier. So this is a slide, this is another review paper that just came out in 2021. And as you can see here, it's really all over the map, looking at the different guidelines. For example, ORSI, the AAOS, EULAR, that's the European Society of Rheumatological Diseases, ACR, of course, the American College of Rheumatology. And it's comparing different injections, corticosteroids to hyaluronic acid to PRP. And as you can see, the evidence is really all over the map in terms of the efficacy of these different approaches. So we know there's some discordance in the guidelines, looking particularly at corticosteroids and HA injections. Corticosteroids, we're learning, right? You've got to be very careful how many times you put steroids into a joint. We now know there's some pretty good literature to suggest that repeated HA injections is quite safe to do. And as you can see, here's a paper that just came out in the journal Cartilage showing that HA injections can actually work for up to 6 months in the hip. And finally is a paper published in 2018, which in contrast to corticosteroids shows that repeated HA injections are quite safe. So here's another paper that uses some fancy statistical work, if you will, using what's known as a network meta-analysis to really try to synthesize the literature looking at different kinds of treatment. This is a really nice paper that I would direct your attention to. And the important take-home message is that high molecular weight HA injections and PRP were really the only treatments that were consistently shown to reduce pain. Specifically then, this is what's referred to as a forest plot. And for purposes of today, if you see the orange line, anything to the left of the orange line shows a good response in terms of pain reduction. And as you can see from this meta-analysis, the high molecular weight HA injections as well as PRP appear to be the most beneficial. We then go on and look at a forest plot looking at function. And again, you can see that it's the high molecular weight HA injections that are really the only agents, if you will, that are to the left of that orange line. And then finally at the bottom is looking at side effects. And as you can see, the good news here is that both HA and PRP injections show good safety profiles. So the take-home message from this, what's referred to as network meta-analysis, is that consistent clinical improvements for both pain and function with the use of high molecular weight HA injections in comparison to saline. There's some benefit to the low molecular weight HA injections. Extended release corticosteroids appear to have some benefit, at least in terms of pain management. PRP shows promise, but the wide confidence intervals make these conclusions uncertain at this point, and that the treatment-related adverse events across the different types of injections is similar. So before we talk briefly about injections, what don't we know? Well, first of all, does the location of disease matter? Does it matter if the arthritis is confined to the tibial-femoral and/or patellofemoral joints? Does the degree of disease matter? In other words, should we be looking at KL grade 1 patients' early disease by X-ray versus grade 3? That question remains unsolved. I mentioned earlier looking at PRP versus hyaluronic acid versus both. And there's some suggestion that PRP and hyaluronic acid together may be efficacious. A topic I'm particularly interested in, after you do these injections, does it matter how you load the joint through physical activity? And finally, this concept I'd like to briefly discuss, and that is, does OA phenotype play a role? I mentioned earlier phenotyping patients. This is not a one-size-fits-all disease, and we certainly, hopefully, that's one of the take-home messages from today's discussion. This is a particular area that we have an interest in here in the University of Miami. And what we're trying to do is to look at our patients with osteoarthritis and phenotype them using this particular paper that came out in the literature back 5 years ago. We're up to about 500 patients now. A lot of them are falling into this inflammatory phenotype. Some of them fall into the metabolic syndrome. And the idea then is to say, if we want to talk about any injection, in particular HA injections, which phenotype would be the most efficacious? And at this point, we just don't know. So let's talk briefly about how to do knee injections. Well, first of all, what are the indications? Well, they can be both diagnostic and therapeutic. It can be to evaluate the synovial fluid, looking for possible infection, rheumatic disease. In the setting of trauma, if we tap the joint and there's blood, there's probably a fracture or an ACL tear in the right setting. Some sort of crystalline-induced arthropathy. Therapeutic, obviously doing a tap of a large swollen joint just to increase range of motion is certainly indicated as well. This is simply one approach, and there certainly is no standard approach to doing knee injections. Typically, I like to use a cocktail, if you will, of triamcinolone, marcaine, and lidocaine. You can see the particular volumes, and again, this can be adjusted to the patient as well. I like to use a 22 gauge needle. Some people will inject with lidocaine ahead of time. I think in the right setting, that's not necessarily needed, particularly if you're putting lidocaine into the joint. And then, of course, making sure you do this under aseptic technique. One thing I think bears a minute or two of discussion, and that is the importance of how you do this injection. So, for example, if you've got somebody lying face up, do we do a suprapatellar injection where we can do an aspiration? Do we do a mid-patellar injection? Or do we simply have the patient sitting on the table and we can use an anterolateral or anteromedial approach? These are just some of my thoughts over the years on sort of the pros and cons of the different approach. Obviously, I think if you do a patellar injection aspiration, that's probably going to be a little bit more accurate. The cons to that, it obviously takes a little bit longer. We tend to do those under ultrasound today. My preference for this approach is if I'm going to do an aspiration of the knee as well as an injection. If it's simply an injection of the knee, I think that the anterior approach works fine. As you can see on the far right-hand slide here, there's the anterolateral and anteromedial approach. Interestingly, done without ultrasound, it's been estimated to not work 25% of the time. My personal idea here is that sometimes you hit that infrapatellar fat pad as well. So again, just briefly looking at the different approaches, as you can see here, this is the sort of anterolateral inferior patellar injection. Patients sitting on the table. If I'm worried about somebody having, some sort of reaction, then obviously I'll do it with them lying flat. But this particular approach works well for me. We can identify the lateral femur as well as the tibial plateau. And I prefer to go in just off to the lateral to the patellar tendon itself. So again, just basic principles. You need to identify the landmarks. I tend to use a pen to mark it, although you can certainly use the sterile tip of the needle. Ethyl chloride spray I like to use. It does seem to help patients. That little sting initially, I think maybe even just distracts them for a bit. Obviously some sort of prep, whether it's betadine or alcohol, so it's done under aseptic technique, and obviously wearing gloves. And what I like to do is if I'm going to do an aspiration, I do that first, but then I can leave the needle in the joint and simply come back with my injection afterwards. So it saves the patient at least one needle stick. So that concludes my discussion this morning, and I think now we can open it for questions. Thank you very much. Good afternoon, everybody. Tom Best from the University of Miami, here in Coral Gables, Florida. Hope you had a chance to visit my earlier presentation. At this point, we'd like to open it for Q&A. So thank you. The first question that is in front of us this afternoon is, could you discuss more on the interaction of HA on intra-articular nerve endings, C fiber, A delta fibers, et cetera? First of all, thank you for the question. And it's a very relevant question because when we think about osteoarthritis and its diagnosis and treatment, which we briefly touched on in my presentation, the major limitation here is that we have traditionally diagnosed osteoarthritis based on x-rays. And that's something certainly that when I started in this profession 35 years ago, that's what we had. We now recognize, of course, that osteoarthritis probably presents much earlier than its x-ray presentation. I would direct you to a paper that was published, I believe, a couple of years ago now, and it looked at not osteoarthritis of the knee, but osteoarthritis of the hip. It was a study that was done at Rush in Chicago, and what it looked at is the predictive ability of x-rays compared to questioning. And long story short, what we recognized was that our abilities to diagnose this disease may in fact be much better with questions and physical examination as opposed to x-rays. The next question, though, is why would that be important? And this has been a major focus not only for clinicians but also for researchers to say, if we diagnose this disease earlier than it presents on x-ray, does it really matter? Because at the end of the day, that's probably what's most important. We don't have that answer yet, right? We don't have that answer. However, when we think about the vast majority of people with osteoarthritis like myself, played sports all my life, participated in all sorts of things, never could define a specific injury moving forward that said, I sustained this injury, I'm going to develop osteoarthritis. We now know that there are not only clinical models, but animal models in the basic science literature where, for example, if you sustain an anterior cruciate ligament tear or a meniscal injury, we know your probability of developing osteoarthritis is high. So we have a defined. So the field is now moving forward to suggest that in a model like that, where you've got acute traumatic injury to the knee, we can now follow these people forward to really understand what are the factors that are going to predict their progression in terms of their osteoarthritis. With respect to the question about nerve endings, again, it's a very important question because at the end of the day, we treat symptoms, right? We don't necessarily treat the x-ray. We know that there's not a great correlation between x-ray findings and physical examination and patient complaints. So for example, I saw a patient in the office yesterday who had essentially KL grade 4 end-stage osteoarthritis with minimal symptoms. In contrast, we have patients who have KL grade 1 or very minor x-ray findings, but have major symptoms. So we need to treat patients and not the x-ray. That said, it's very difficult at this point to understand the relationship between HA injections and pain and nerve endings, right? So how do HA injections work? Well, the postulate is that they provide some relief, if you will, of articular cartilage damage. Articular cartilage does not have nerve endings. And so, although it's been postulated that HA injections may in fact reach the nerve endings, we know that articular cartilage doesn't have nerve endings. So that's a really important question because when we treat patients, we treat pain, and other symptoms such as stiffness, loss of range of motion, various subjective and objective measures. The next question that I see here is, do you inject HA into other joints than the knee? And the short answer is yes. We've had good success over the years with HA injections off-label for the hip. It's interesting that it's a weight-bearing joint like the knee, and perhaps we can talk about this if time permits, because people are now starting to use HA injections for the glenohumeral joint of the shoulder. I happen to believe personally that it does make a difference whether you're injecting a weight-bearing or a non-weight-bearing joint. The second point is we also need to understand and really figure out, when we talk about the knee, we have the tibiofemoral joint and the patellofemoral joint. And question in my mind, at least as a clinician and as a scientist, is, does that matter? Does it matter if I have tibiofemoral osteoarthritis or I have patellofemoral osteoarthritis? I don't have the answer for that question, but I think it's important as we move forward to develop the appropriate studies to look at that so that we can educate our patients and really understand what are the best indications for HA injection. The next question that I see here is, how long do you wait before repeating a series of HA injections if the patient is symptomatic? 6 months. Well, that's a really interesting question again, because if you think back maybe a decade ago, for example, roughly a decade ago, insurance companies were allowing us to utilize these injections as frequent as every 3 months, right? So 3-month intervals. So that would mean you would get some sort of injection every 3 months, so that's four injections each year. I was personally opposed to that. I felt like if you needed an injection every 3 months, I don't have the data to support this necessarily, but I felt like if you needed an injection every 3 months, that was probably not something that was working for you. I think it's very difficult. A lot of our patients present to us very desperate, which I understand is somebody who's got end-stage, again, osteoarthritis of my right knee. We have a tendency in medicine to want to make sure that for all the right reasons that we, help our patients, we give them what they want. That's a question that hasn't been answered yet, right? What's the optimal number of injections each year? I think back to when I started 35 years ago, we had corticosteroids, and we would administer these injections every 3 to 6 months, and not knowingly, of course, recognize that maybe too many corticosteroid injections can be deleterious to joints, particularly when you look at chondrogenesis and actual chondrocyte, the basic building block, if you will, of articular cartilage, right? We now know that too many injections, maybe more than twice a year, inhibits chondrogenesis. So we've learned over the years, right, that sometimes too many is too many, as they say. The next question that I see here is, for patients with a unicompartmental replacement, do you utilize HA in their knee to treat OA in their non-op compartments if they become symptomatic? That is a really, really good question. Let me preface it by saying that I was trained in the era where a lot of our patients presented with what's called varus knee, so they were bow-legged, like myself. They had unicompartmental changes, primarily in the medial compartment, not surprising, right, with the varus knee. And you would do a uni, or you would do a so-called high tibial osteotomy, which is still a procedure we use today, right? If you look at anterior cruciate ligament reconstructions in a varus knee, often you will not only reconstruct the ACL, but you will correct that varus informative. I think the jury is out there looking at patients who've had a unicompartmental, primarily, again, typically the varus knee, right, with that medial compartment change. They go on to develop, or at the time have concomitant lateral compartment, patellofemoral compartment changes. I don't necessarily have data to support this, but I will tell you that patients who have patellofemoral compartment osteoarthritis, that's very difficult to treat, right? These are the patients that have difficulties walking up and down stairs. They flex their knee to 30 or 40 degrees of flexion. They become symptomatic. These are very, very difficult conditions to treat. And I throw everything at them, including HA injection. I believe at this point, there are no further questions. So we're going to end this session. I appreciate your attention this afternoon. And obviously, I'm available to answer any other questions so that we can all learn together and ultimately advance the care of our patients. Thanks very much for your attention this afternoon.